So even though we are using femtosecond laser for so many applications and trying to replace the manual technique or the microkeratome with the femtosecond laser, complications do occur with femtosecond laser which are unique to femtosecond laser, and also some of them which are flap related or cap related, which would still occur when we do these techniques with the conventional method. The complications that can occur after femtosecond LASIK include the subconjunctival hemorrhage, the gas bubbles in the AC, the gas bubbles breakthrough, transient light sensitivity syndrome, the rainbow glare, and the diffuse lamellar keratitis. Now, these are the studies to show the same. That is, with the intralase, the complication rate is 0.9 to 0.13%. The flap related vary from 0.13 to 2%, and the post-op complications vary from 0.3 to 0.7%. You can have subconjunctival hemorrhages such as this because of repeated application of the suction ring, and less subconjunctival hemorrhage has been reported when the pre-op brimonidine was used. There could be also gas bubbles in the anterior chamber. The mechanism is that the stray femtosecond laser goes directly into the aqueous or through the trabecular meshwork, but generally it is self-limiting and does not have any long-term effect, but it does interfere with the laser eye tracking system. So this was a case of wherein LASIK was being attempted, and after the side cut as well as the main cut was made, there is a OBL, or the opaque bubble layer, that is present, and small air bubbles were present inside the anterior chamber. So one can deal with it in two ways. One is that you can wait for the air bubbles to disappear, or you can put the tracker off and continue with your ablation, ignoring the air bubbles. Now then, there can also be what is called as vertical gas breakthrough, because femtosecond laser creates light-induced optical breakdown in the interface. The gas, it dissects along the plane of least resistance, and they migrate vertically. So when this happens, you will see it as a black island, such as this here you can see near the hinge. So if there is a vertical gas breakthrough, the management is that you have to stop immediately and release the foot pedal, and if it occurs prior to the side cut, then the flap or the cap is still intact and will not move, then you can repeat the laser from the opposite direction at a deeper cut by 50 microns. Vertical gas breakthrough, however, in the post-op, in the intra-op as well as the post-op period, can cause flap tears, buttonholes, increased propensity for epithelial ingrowth, as well as flap stria. So this is a case where you see that there is a vertical gas breakthrough which has occurred just at the initiation of the hinge, and so in this case the surgery was planned at a later date. Now, what has been advocated is this. So if there's a gas bubble breakthrough which extends in front of the advancing laser edge of the flap, then one has to abort the LASIK procedure and recut at a later date. But if the gas bubble breakthrough occurs behind the advancing laser edge of the flap, then the flap can be lifted carefully and the laser can be completed. Of course, with the area of the breakthrough, you will have difficulty in removing the flap from therein. Then there can be micro adhesions. The minor adhesions can be carefully broken up, but to break larger or more coalescent adhesions, one can cause flap tears or pseudo holes. And when that occurs, then you have to check your energy level settings and readjust again for the next case. Then the suction break can occur, which can lead to incomplete flap because of tight orbit or squeezing or improper positioning of the suction ring or entrapment of the lashes or conjunctiva. And this can occur at the raster stage or during the side cut. So if there is no side cut, then the procedure can be still completed immediately at a greater, using the setting at a greater depth. But if it occurs while making the side cut, then do not lift the flap or the cap, and you have to retreat later with a smaller flap at a greater depth. Sometimes you can even do a surface ablation provided the refractive error allows you. Now in this case, there was a suction loss in the middle because the patient moved the eye, and by the time the side cut had already been done, And this is the surgery which was planned 3 months later at a depth which was 40 microns more. But notice that there is still a silver or a spindle that remains, and one has to be careful while lifting the flap because for the presence of this peripheral spindle which may remain. Now sometimes there can be also eccentric flaps or caps, such as in this case. And when this occurs, again, you have to, just before the side cut occurs, you have to stop and go at a depth which is 40 to 50 microns below the one which you had planned earlier. Now, you can have an opaque bubble layer, and this opaque bubble layer is because of the collection of the gas bubbles. It can interfere with the surgeon's view, and it may obscure the patient target as well. But with the lasers which have come now into vogue, this opaque bubble layer doesn't actually happen much. It used to happen with the previous generation lasers. But if it occurs and if it obscures the patient's view, then you have to wait till it disappears. Then in cases of keratoplasty, the complications which can occur include the perforation, incomplete donor or recipient cut, the post-op stromal rejection, and the raised intraocular pressure. If the Descemet's membrane perforation, if there's an inadvertent perforation, then you can still get away with the perforation and complete your keratoplasty. The risk of intraoperative perforation is 11 to 15%. And most of them are small, but if they are macro perforations, then you have to convert to a penetrating keratoplasty. Then again, incomplete bed cut or side cut can occur, and I think this has already been dealt by Dr. Amit. The only thing to show is that sometimes you can have adhesions at the back which may be still present, and you may have to remove them and excise them with the help of the Warner scissors. So in this, mushroom cut was planned in the donor, and an attempt is being made to remove the entire lenticule. But at one edge, it is still uncut, and you may have to use the Warners or the scissors to excise these remnants. Then sometimes, especially when you're doing superficial keratoplasty, then while removing the anterior lamellar button, there may be a beveled spindle which may be left, which needs again to be addressed. While putting it on the recipient, one has to remove this edge just at the last bit. It goes on the other side, and there's a small bevel of tissue that is remaining, which one has to remove. Okay, so these are the various studies, and you can see that the rejection varies from 3 to 15%. The IOP spike is there in 4 to 42%, and the Descemet's membrane perforation rate varies from almost 5 to 15%. And again, this transient light sensitivity syndrome was reported with the lasers which were of older generation, but not so now. Apart from this, there can be loose epithelium, again, which is less with the femtosecond laser. And epithelial ingrowth is also less because the wound configuration is absolutely matching. There could be diffuse lamellar keratitis such as this, which needs to be taken care of. And to conclude, there are lack of studies which are comparing the different femtosecond laser platforms in terms of complications, and the evolution in technology and techniques will decrease the complications further. Thank you for your attention.